Welcome everyone to Conversations in PAH, an expert discussion on clinical updates and treatment options in PAH. Today we're going to talk about three different topics: an update on pediatric PAH care, patient perspectives in PAH, and also what's new in imaging in PAH. I'm Ronald Oudiz. I'm a cardiologist at Harbor-UCLA Medical Center, and I run the PAH program there. And I'm proud to introduce Drs. Dunbar Ivy, who is co-director of the Heart Institute and Chief of Pediatric Cardiology at the University of Colorado, and Dr. Marc Humbert, who is a professor of respiratory medicine in Paris and director of the Central French Reference Center for Pulmonary Hypertension, basically for the entire country. These are our learning objectives. Upon completion of this activity, you should be better able to review the diagnostic and treatment challenges in pediatric PAH and discuss key differences in the screening and management of pediatric versus adult PAH patients. You should be able to utilize evidence-based medicine and expert opinion to manage pediatric patients with PAH and examine how clinical teams can acknowledge and embrace the individual patient's perspective and improve the care for individual patients suffering from PAH by cultivating the importance and relevance of health-related quality of life in direct clinical care. And finally, to review the role of current and emerging imaging modalities in the setting of PAH. So we'll start off with Dunbar giving us an update on pediatric PAH care.
Well, thank you, Ron. It's wonderful to have this symposium discussion. And for me, pediatric PAH has been an exciting field, and the challenges continue, but we continue to make progress. And one of the challenges that we have is we have very few medications that are approved for children with PAH, and this includes challenges in determining a primary endpoint for trials and also for agency approval. And currently in the US, the only drug that's FDA approved is bosentan. And maybe when we get to the discussion of some of the drug trials, we can discuss this. The FDA used extrapolation to adult data to approve bosentan. And you may remember that the sildenafil trial, the STARTS-1 trial was not positive. And then in STARTS-2, there was a potential signal for an increase in mortality with an increase in dose over 3 years. So we still have a lot of challenges in terms of drug approval. Nonetheless, we have a good working group and a group of experts that give their opinion, and we have some recommendations for treatment. And as said here, one of the changes was at the last symposium was decreasing the mean PA pressure to 20 for the diagnosis. And for us, this was totally acceptable because in some of our children who are much smaller, that was fine. And furthermore, very few of our patients in registries had mean PA pressures of 20 to 25. So most had a mean PA pressure of over 25. So, I think that, we have had some exciting findings, and we'll discuss those throughout the rest of this discussion.
Dr. Ivy, you recently published an update on pediatric PAH. Can you provide a brief overview of what is new in pediatric PAH care? That's a tall order question.
Yeah, I think one of the several of the exciting things are in imaging because children have better windows. We're able to do more 3D imaging for RV function. We still use MRI, but then you have to sedate the younger kids. There's been a marked increase in knowledge about genetics, in particular TBX4, and we'll discuss later that the landscape of pediatric PAH is different than we thought, with many more patients with forms of chronic lung disease, particularly developmental lung disease.
We're looking at at a proposed diagnostic algorithm that is pediatric oriented. Can you compare and contrast how it relates to the adult algorithms?
Certainly. This is from Georg Hansmann and the German working group. And obviously, it tries to encompass all potential diagnoses. But I think that one thing that's certainly different is the prevalence of the diseases that we see in children versus adults. And you can see early on that we look for congenital heart disease and chronic lung disease. And what we don't see as much early on is scleroderma or other connective tissue diseases or chronic thromboembolic pulmonary hypertension. However, I would say that it's extremely important to look for these disorders. And we all know that CTEPH is, one of the few quote unquote treatable causes of PH. So I think one thing that this does is to remind us to look for all of these diseases in our patients with PH. There are similarities in terms of cardiac catheterization and what to do with that information, which we could discuss later. And I think this slide also points out that genetic counseling and genetic testing is important. And I'll show some data later on from Professor Berger that shows that there are outcome differences based upon the genetic background.
Dr. Humbert, is there in France a separate task force or governing body, if you will, that oversees pediatric patients differently than the adult patients?
Yeah, thanks, Ron. First, it's a great pleasure to be with both of you today. It's really good to see you. In France, we have organized pulmonary hypertension management as a single entity with a referral center, but there are some pediatric centers which are devoted to the kids' care. And there is a lot of emphasis on the transition from kids to adults. And we try to put a lot of emphasis on the smooth transitioning from childhood to adulthood period. That being said, we have multidisciplinary meetings, and the pediatricians are always very important to discuss their key messages, as Dunbar said. I mean, there are some specificities in kids which should not be forgotten. But we work as a network together with pediatricians, and we try to work as a multidisciplinary team.
Now, obviously, there are some similarities as well as important difference in terms of risk assessment. So looking at the way the pediatricians approach risk, there seems to be a sort of a similar low risk versus high risk. But what, Dr. Ivy, is the approach that you use at the University of Colorado? Do you segregate into sort of low, medium, high risk, or do you use risk scores and categorize based on severity that way?
That's a great question. This is from the World Symposium, and I think that we are more, as I said before, experience-based than truly evidence-based. We don't have the number of papers to categorize risk, and so you can see that we just see low and high risk, but in adults, that's based upon 1-year mortality, less than 5 to 10, and greater than 10, and we didn't have that data. And so you don't see an intermediate risk group just because we have not been able to define that. I think many of the features of high risk are similar to the adults. And again, we adapted the adult low, intermediate, and high risk for pediatrics based upon sometimes only a few papers. But, I think low 6-minute walk distance, functional class 3 and 4, NT-proBNP, I think, is routinely used. We have some different echo parameters than the adults, but many similar ones. We do use TAPSE, but personally, I like the increasing use of 3-dimensional echo and other echo imaging techniques, which may not be possible in a larger adult. And then our hemodynamic data, what is characteristic of children is that they, even when they present in functional class 3, usually their cardiac output and right atrial pressure are relatively well maintained. So these are values, the number of patients with very low output or high right atrial pressure is low, but they are very poor prognostic characteristics. So our treatment algorithm really looks more at low and high risk rather than low, medium, and high as you would see in adults.
And that sort of jives, I think, with what Dr. Humbert's group in France and others are sort of tending to now, the idea that you're either low risk or you're not. And the goal is low risk. Have the pediatricians sort of adopted that same stance in their
Yes. Just a quick addition, we do in the older child, particularly with IPH or heritable, we do use the risk scores for adults. But as you said, particularly Dr. Berger in the Netherlands looked at the number of low risk features and as has been shown by the French group and others, that is predictive. So I think we are shifting more towards let's get as many low risk factors as possible rather than just looking at high risk factors.
Dr. Ivy, there are a plethora of studies currently ongoing in pediatric patients with PAH. So I'd like to focus on a couple of publications, some of the more recent ones. Can you comment on a recently published phase 3 trial with tadalafil and a phase 2b with ambrisentan in children with PAH?
Certainly. I think these two trials show the major challenges that we still face in terms of trying to get adequate evidence-based treatment for children. I think what these two studies will show is that the trends are similar and that we feel that the safety of these drugs is very similar to adults, but in terms of trying to get evidence, and particularly evidence to get labeling for drugs in children has been an amazing challenge. And so this was a phase 3 randomized double-blind placebo-controlled trial of tadalafil in children, and patients were going to be placed into low or heavyweight, middleweight, and lightweight. What you can see is that the initial treatment target or number of patients was 134. And after 5 years, the study didn't enroll. So the company went back to the FDA and actually changed the primary endpoint from time to clinical worsening, which we felt would be a good way, to show efficacy. But the number of patients was so low that they changed it to 6-minute walk. And further, there were no official statistical analyses because of the low number of patients. Irregardless, as you can see here, the trends were quite similar. There were about 34 patients in this trial. They used a least squared mean analysis of 6-minute walk, which showed about a 20-meter difference, and then using a placebo-adjusted difference, because there was a placebo group, which was about 24 meters, which I think most of us would say is modest and maybe more modest than we would like. They did a Bayesian analysis, and then we did see a nice trend in terms of tadalafil's effects on decreasing in those treated and maybe even increasing a little bit, and those were in the placebo group. So again, I think it confirms that this drug is, probably safe, may be effective, but we don't have that level of evidence to get a label. And then when you look at ambrisentan, this was a randomized trial was not placebo-controlled. It was on background therapy. You can see, again, the study was to have over 60 patients, and after 41 patients in many years, the trial was stopped, which I'll give a comment on later. And there was low and high dose in different weight groups, and the data you see on the right really is just descriptive, no statistical analyses. So in the lighter bars is the low dose, darker is the high dose, and the 6-minute walk mean for both groups together did improve. Functional class was maintained or improved in most, and there was very little event worsening. About 85% in both groups did not have worsening in this trial. And likewise, NT-proBNP was favorably changed. One interesting thing about this trial is at the same time, the company was doing studies in juvenile rats and showed that high-dose ambroxetine in very young rats caused some pharyngeal abnormalities. And we don't know what to do with this. And so the trial was stopped for that reason. This abnormality has not been seen in any humans, and they're continuing to do some studies, but what to do with that information, we're really not sure. But again, both of these trials showed similar trends, no real evidence of efficacy, but I think reasonable evidence of safety.
And similarly, what does the recently published upfront triple combination study show about initial treatment strategies in children with severe PAH?
So there is a recent study that was published by Professor Berger at the Dutch National Center and Professor Bonnet. And this work was inspired by Professor Humbert's work. Again, it was retrospective and looked at any patient that they had at their center between 2010 and 2019 that were started upfront combination therapy, I believe, within 1 month. And they looked at many of the parameters that we normally look at. And on the right-hand side, you can see that in the 19 children, overall survival was good. But if you look at death, lung transplant, or POTS, you can see that about half of the patients had a POTS shunt, which is a connection surgically between the pulmonary artery and the aorta, or a lung transplant. There were 2 patients who died within the first 2 years, and they were both found to have veno-occlusive disease. But if you look at the very bottom, you can see there were quite a few events. There were quite a few lung transplants or POTS shunts. So I think this is encouraging, but I'm curious to see Professor Humbert's thoughts, because I think the French experience was a little more positive than this. The survival was good, but a lot of transplant or POTS shunts.
Thank you, Dunbar. Indeed, it is interesting data. In adults, we based our approach on risk stratification, as we just discussed, and in younger patients with very little comorbidities and high risk of death, we decided to offer these patients initial triple combination with a parenteral prostacyclin, of course, not with another way of administering prostacyclin. And we did show impressive improvements in outcomes in those people. We reported that twice, once the first experience in the European Respiratory Journal as early as 2014, but very recently in the American Journal of Respiratory and Critical Care Medicine, we did show the whole spectrum of initial strategies and outcome. And clearly, in the people who were offered initial triple with the parenteral prostacyclin, the outcomes were clearly better. but it is always difficult. It is not a randomized controlled trial. And of course, we did some subsequent statistical analysis, which seemed to be in favor of such a more aggressive approach in people with less comorbidity and severe presentation.
So I'll add that, again, without evidence, and I'm reminded by our federal agencies that we don't have evidence to do this, but we are using much more upfront dual combination therapy in children, and particularly in those patients with idiopathic, heritable, and post-congenital heart surgery. And in some, we are using upfront triple oral combination therapy, again, really without evidence. And then in the severe patients, we have used intravenous therapy.
In adult clinics, at least in my clinic, it's not uncommon that patients are resistant to upfront triple combination therapy, particularly resistant, even if it's not triple therapy, to intravenous or subcutaneous infusions. But I'm curious, in the pediatric populations where you have the parents, do the parents prefer to be aggressive, or are they as shy as the adult patients?
I would say sometimes, unfortunately, they're very resistant to a continuous prostacyclin therapy. And I think when Robin Barst, in the 90s was advocating for IV therapy, I think there's a sense that we may have better outcomes, that we're delaying further and further, more aggressive therapy because of the option of oral therapy. So yes, many parents are very resistant to subcutaneous or intravenous therapy.
If I may jump in, it's very important indeed to consider that, and also to state that the patient association can have a very strong role to convince the more aggressive approach when it is needed, of course. And you emphasize that evidence remains emergent, but it is important to sometimes partner with patient association to commit the patients a little bit more.
Dr. Ivy, what is the Pediatric Pulmonary Hypertension Network, or PPH-NET registry, and what are the aims of the research on that registry?
So this is a group of 13 centers that have a dedicated focus on pediatric pulmonary hypertension, that have, the full gamut of nurse practitioners and ability to use any drug therapy. And I think, in pediatrics, PAH is a rare disease. So by combining centers, we're much more able to get an idea of the landscape of the disease and to do some clinical trials, and then also to ask questions. So, for example, our group looked at TBX4, and Steve Abman was a major driver of that initiative and of this registry, by the way, or this network, by the way. But I think we have regular meetings. We have sort of a triple aim of, looking at the landscape of disease. We're beginning to look at interventional trials, which we'll discuss in a minute, but also education. So we get together once a year and sponsor a meeting, usually in San Francisco, for training of other centers or the one person who's taking care of PH. So I think this group has come along nicely, and it's really been to the dedication of the investigators and their teams. And the other thing that's been nice is that our nurse groups within this network are beginning to write publications about, for example, ways to maximize therapy with subcutaneous treprostinil, and try to have a common approach to that. So for us, it's really been an important advance, in getting together and working together.
Great. Before we wrap up the discussion on pediatric PAH, I want to talk about one study in particular that looks at the genetic epidemiology of pediatric PAH.
So this is a paper from the Dutch National Center, and Professor Berger was, I believe, the first to show that TBX4 was causative for PH, and it also is a gene that causes small patella syndrome. But the very interesting thing about this gene is that it sort of has a lung limb phenotype, and Professor Humbert can comment. They've done some very nice work with this as well. But Professor Berger sort of looked at different groups and looked at the survival within those groups, and you can see that those patients in this cohort with TBX4, their survival was very good. And our data was a little different. Some of the neonates died. But next you could see that the patients with congenital heart disease and then those with BMPR2 were relatively similar in their survival. And as expected, patients with veno-occlusive disease did incredibly poorly. So this was one of the first studies for us which really looked at, is there a difference in survival based on your genotypic background?
If you could provide maybe a summary of what we just talked about in pediatric PAH, Dr. Ivy.
Certainly. So we're learning a lot more about pediatric PAH. I think that we're providing better care for our patients and also advocating for them. It's a very heterogeneous group. We're seeing more and more children with bronchopulmonary dysplasia, congenital diaphragmatic hernia. Diagnosis is crucial, just as it is in adults, and it's important to look for all causes. And I have to remind my other colleagues that we really do need to look for thromboembolic disease because this is a quote unquote curable form. We follow similar, not exactly the same, but algorithms for risk and treatment, and this includes cardiac catheterization with vasoreactivity testing. Most of the studies are based upon adult data, but we are having smaller trials that give us an idea of dosing and safety with some evidence of efficacy, and the trend for these trials is similar to that for adults, but obviously we need to keep performing studies to try to maximize therapy and hopefully get more drugs labeled for children.
That was a wonderful discussion.